will be leading us through our Norse Family Conference this morning. I really want to thank Dr. Tanil Gofton as well for her help with planning this today, and Nora Wong, of course, and then Maggie, Gopal, and Matthew, who have been instrumental as well. Here's just the agenda up on the screen just so we can keep track of what we'll be covering today. The focus is really medical updates and then also improving doctor-family communication. We'll have a variety of initial talks followed by a Q&A time from 11:15 to 11:30 where we can have people raise their hand in the chat and raise their hand to ask questions or type things into the chat. And then that'll be followed by a break and then some breakout sessions. A couple of different housekeeping things for everyone. If your name isn't showing up on the screen already, if you can rename yourself so we know who everyone is, that'll help when we get to questions through raising the hand during the Q&A panel as well. We'll also respond to questions in the chat throughout as well. And then for the breakout sessions, when those come, you will have the option to select which breakout room you want to be in. They are all overlapping sessions, so you'll just end up being in one breakout room. And those will end at 12:25 p.m. Eastern time, and then we'll have a few minutes for wrap up at the end. And then if there is any other kind of housekeeping updates, we'll update you about them along the way. But again, thank you everyone for joining. We're really excited for the second day of yesterday we did the Norse Scientific Symposium and today the Family Conference. And so we'll go ahead and get started. I'm going to stop sharing my screen and we'll start with a summary of some of the things that were discussed yesterday with Dr. Hirsch.
Okay, thanks. So I was just going to give a summary of the symposium yesterday more than of the file repository, but a tad of both. So let me see if I can share. I'm just going to pull up the agenda. That'll be easier. Okay. So here, this was the agenda for yesterday. So Jim Riviello led the scientific symposium, and it was really concentrated on early was the case. So early recognition, early treatment, early communication of Norse and fires. And virtually every speaker concentrated on that early part. So it started with Ronnie Wickstrom from the Karolinska in Stockholm, Sweden, and he talked about recognizing Norse and fires and the clinical features that can help with that and how we can get people to recognize it earlier. So specific things he talked about was there's a new scale called the cryptogenic Norse scale. That's just 6 questions about clinical features that can help people identify a case of Norse very early and differentiate it from some other diagnoses. And it has actually been somewhat verified in other populations. So that's somewhat new. And he also talked about using certain diagnostic features to tell the difference, including things like the cytokines, that the inflammatory markers that we measure in the blood and spinal fluid, and some other markers that can help in the very early stages in telling the difference. Similarly, the next speaker was Raquel Farias-Muller and Yi-Chen Lai. They talked together about biomarkers. So Raquel talked about EEG and MRI features and trying to tell the difference. As far as EEG, there are a couple findings that seem to be much more common in patients with Norse and fires, including the pattern during seizures and a pattern between seizures as well, called delta brushes. And Yi-Chen Lai concentrated again on the cytokines, so the pattern of inflammatory markers and how looking at many markers together and the different pattern of them can help identify Norse early and tell the difference from other conditions. And he also pointed out that those are actually hard to get clinically. And there's a very recent study that he's leading looking at CBC. So those are regular blood counts that are done almost every day in people in the hospital. And it looks like they are actually certain features of those blood counts are predictive of outcome. And that's just research that's finishing up now. So a very practical study. Then Nicholas Gaspard talked about mechanisms of why some seizures become refractory and don't stop and don't respond to treatment. And it's mostly related to different receptors and neurotransmitters. As seizures continue, the receptors that things like benzodiazepines and that's Ativan and Valium and those things, the receptors that those use get internalized into the cell, so they no longer work. And some of the more excitatory ones, the one that makes seizures worse, actually increase and get sent to the cell, to the outside of the cells and become more active. So it implies that different drugs will work in the later stage. And that actually has led to some trials that are already starting of using ketamine earlier. So ketamine is an anti-NMDA and anti-glutamate agent. So it acts differently than all the benzodiazepines and barbiturates. So it doesn't work on the GABA, but it works on the ones that are upregulated, the excitatory ones. So that's a trial going on now, adding ketamine very early in status epilepticus, not specific to Norse, but all status epilepticus. And then he also mentioned transcranial direct current stimulation, a new, very benign way of doing stimulation on the scalp that does reach the brain and seems to be showing a little bit of signs of efficacy, but it's still early on that. Then we talked about promising immunotherapy. So Kristen Fisher specifically talked about intrathecal dexamethasone. So that means into the spinal fluid directly. So that's by a lumbar puncture or spinal tap, injecting steroids to decrease inflammation directly in the brain and around the brain. And there's been several series of that published that looks promising. We just published one from our biorepository. And Kristen was proposing early use of that, probably right at the time you're starting other second line immunotherapy. And then Eyal Maskal, our rheumatologist, who's been very involved with all of our studies, he talked about all the different pathways and molecular markers. Gets very complicated, but there are many with potential utility in Norse involving a whole bunch of markers and interferons and interleukins and all these inflammatory markers. So lots of things that still theoretically should help and need to be studied. And then Lakshmi gave just a beautiful summary of what it was like going through her son's acute Norse phase and surviving it for 7 years since, her son Nishant, and particularly stressed in the acute phase the importance of having a consistent team and a consistent plan and not constantly changing the story. I think that's something that resonates with a lot of patients and a lot of doctors. That's one of the biggest challenges. And then Krista talked about prognosis and communication, which I think you'll hear a lot more about today. But stressing all the communication challenges in a rare disorder with little details and little ability to predict outcomes, and very long hospital stays with many teams involved and many services. And she did mention that there is some useful literature in the neonatal ICU world, including a real framework on how to approach communication. And then I gave a short update on our Norse Fires Biorepository. So that's still ongoing. We have well over 100 patients with samples in the biorepository and many groups around the world who've taken our samples and started doing research, some of which was presented in this symposium. And then we announced the big news that we have gotten the award from PCORI, the Patient-Centered Outcome Research Institute, to do a clinical trial of anakinra versus tocilizumab for treating a Norse at day 7. And this is something where I'm the PI, Dr. Gopal on here, Dr. Eschbach, and Dr. Wong, all on this call right now, are the co-PIs of that. And that will be a 5-year, 33-center international clinical trial So we'll get some real high level information on that, and we'll learn lots of other things as well. That's going to have over 300 patients in it. So we should learn lots of things for that. So that's kind of the summary of what happened yesterday, and I'm happy to take questions if we have time. Not sure if we will or not. Let me stop sharing.
Yeah, we actually have, we do have a couple minutes if anyone has any, specific questions about any of the updates or the biorepository or the PCORI award funding. If not, you can write them in the chat and we can answer those as we go along as well. Not for right now, which is fine. So the next thing, thank you for, those updates. The next thing that we'll move on is to thinking a little bit about medical uncertainty and communication. And I think what we thought a nice approach would be for this is to hear both the family perspective and then also hear from two clinicians about their perspective in terms of communication around the time of diagnosis, and then also, after transition out of the intensive care unit. So we will have Desiree will speak initially as a parent on surviving Norse, and then we'll also hear from Janie Yang and Ranjan Roy as well, who will speak about their experience with Norse and losing their loved one and the impact of that and how communication and the family perspective. And then lastly, we'll hear from Dr. Fisher, who is a neuroimmunologist at Texas Children's Hospital and follows patients both during the acute period and also after their discharge. And then Dr. Lai, who is a intensivist at Texas Children's Hospital as well. So again, getting some different perspectives around what can be challenging conversations and how to, hopefully we'll have some takeaways about how we can do better with that as well. So I'm going to go ahead and stop. And Desiree, if you want to go first. Thank you.
Thank you for having me and allowing me to share my experience. My son David was diagnosed with Fires in 2017. He is now 8.5 years post-onset. During the acute phase, we actually had what I consider a very good experience, remarkably so, considering it was the worst time of our lives. David was admitted to Nicholas Children's Hospital in Miami. There, we were fortunate to meet a particular nurse we could request on her shifts. We requested her because every time she came into the room, she took the time to explain exactly what medication she was administering, what class it was in, why David needed it, the dosage, and when the next dose was due. When she was on duty, we didn't feel like bystanders. We felt like participants in David's care, even when we couldn't do anything physically to help him. Although many neurologists came and went in the PICU, there was one neurologist we knew David belonged to. She oversaw his care. If there was a question about next steps, our first thought was, what does Dr. Hislop think about this? That clarity, knowing who was responsible, set our experience apart. We knew who to turn to, and that gave us a sense of stability in the chaos. There was one moment I'll never forget. David's neurologist burst into tears while speaking to us about how much she wanted David to succeed. Some might consider this behavior unprofessional, but it gave us hope. It showed us David wasn't just a case. He was a little boy whose life mattered to her. Doctors, I implore you, please don't be afraid to show your humanity. Your compassion might be the very thing that gives a family the strength to keep going. It might be the bridge that builds your trust in the care you're providing. That trust, however, becomes harder to maintain in the chronic phase of the syndrome. David is now 8.5 years out. Our focus today is on balancing seizure control with his quality of life. And that balance is not theoretical. It's daily, practical, and very real. If a medication controls his seizures but sends my son into mania or violent rages, it's off the table. That's our line. We once tried a medication that became problematic every time we exceeded 1.5 mLs BID. David became violent. I documented the increases, the behavioral changes, and even pointed out that the same reaction had occurred during a prior trial of the same drug. When I told the neurologist it wasn't working, he said, "That's not a commonly listed side effect. We can refer him to psych if you like." For months, I was dismissed, even as I was being attacked by my growing teenage son, even with detailed logs, even with a clear pattern. Finally, I insisted we return to 1.5 mLs BID. And of course, the violent episodes stopped. Another time, with a different neurologist, David was having silent seizures at night, not moving at all, quietly seizing and desatting until he turned blue. My husband and I took shifts, staying up at night just to make sure he made it through. We begged his neurologist for a medical grade pulse oximeter. "That's not standard practice," he said. Thankfully, David's pediatrician had the heart to write the prescription. These are just two of many occasions I was treated as if I brought no value to the table. I want to highlight those specific phrases, not a commonly listed side effect, and not standard practice. Because here's the truth. There is no true standard in the chronic phase of Norse or fires. Yes, chronic epilepsy is common, but no epileptologist can predict which medications or interventions will work for a given individual. Each patient is different. Treatment must reflect that. Treatment must be individualized. I've become an expert in my son's particular brand of fires, and I say that with confidence. I track seizure trends, I log medication changes, side effects, withdrawal timelines, and behavioral shifts. David's life has been saved countless times because I insisted that my observations were real, despite them initially being dismissed as behavioral health issues or signs of disease progression. In fact, these were symptoms of markedly elevated ammonia levels related to anticonvulsant titration, interactions between concurrent anticonvulsants, and other adverse medication effects. In the chronic phase of David's case, he is the subject, I am the lead researcher, and the majority of the data needed to treat him lives with me. A neurologist cannot create a successful treatment plan without understanding that. Dismissing me means dismissing the largest, most complete data set available. No good doctor wants to make decisions using insufficient data. Thankfully, with relentless advocacy, we've been able to individualize David's care. But progress has rarely come from the system. It has come from me continually researching peer-reviewed studies, presenting them, and pushing for action. In a perfect world, his doctors would bring the research to me, saying, "Look at the possibilities," instead of, "That's not standard," or "That side effect isn't on the list." But since we don't live in a perfect world, I'm taking steps to create one for him, and that begins here. To the doctors and professionals in this room, please don't treat families like secondary participants in their loved one's care. We are not just caregivers. We are data collectors, observers, advocates, and often the difference between a treatment plan that works and one that fails. Trust us, listen to us, collaborate with us, because in this rare, unpredictable condition, partnership isn't optional, it's essential. Thank you.
Desiree, for sharing your experience and highlighting really just how important it is to have parents and families, patients as part of the care team and listening to them. I think you have so many points that we can learn from, take away from. Thank you. Can move over to Janie and Ranjan, let you guys share your experience.
Thank you. Thank you, Desiree, for sharing your experience, and thank you everyone for giving us the opportunity to share ours today. My name is Janie Yang, and I'm here with my husband, Ranjan Roy, and we're parents of Samaya June Roy Yang, our beloved daughter who passed away 1 month shy of her 7th birthday on November 18th, 2023 from fires. Just to give you a little bit of background, everything happened very quickly. It really just began with a simple fever that occurred on November 10th. And by the evening of November 14th, we were rushing her to the ER at NYU Langone Children's Hospital located in Manhattan, where we live. Just as I was in the ambulance with her, and just as we were approaching the hospital entrance, that's when she had her first seizure, and it just never stopped. We didn't know what was going on, and despite the incredible efforts of the ICU team, Samaya passed away shortly after, like 4 days later. And so, to be quite honest, that entire week was a complete blur. We were overwhelmed by the unknown, what's happening to her. We didn't know what was causing the seizures. We were confused by everything that was happening within the ICU. But during the entire experience, there were two things that really stood out to us during those days. And I think it's really consistent from what Lakshmi has shared with you all, just in terms of the consistency of communication from the medical team with each other and with us. And also just drawing from what Desiree just mentioned, just in terms of the partnership, how important that is, and how empathy, how it comes through, and really just acknowledging our observations as parents rather than dismissing the noticings that we had, because we were in the room with her 24/7 during those moments. And so I'm going to pass it on to Ron John right now. He's going to go ahead and just focus on those 2 points, just the communication, the importance of the communication, the consistency communication amongst the medical team, and then also how empathy, how important that piece is during the entire process.
Yes, so I'm Ranjan, father of Samaya. I think, again, overall, there was a lot of doctors, a lot of nurses who really made the experience comforting at times. But I know that the goal of today is to try to kind of walk through where there could be areas of improvement and kind of breaking down what Janie had said. So first, on communication, there's two parts of it to me that stand out. One, at NYU, and recognizing at a larger institution, the good and bad is you have experts across the board, but the bad, not having a single point of contact, even trying to learn what an epileptologist, rheumatologist, nephrologist is all overwhelming, was all overwhelming for us. Being in the worst situation and trying to process concepts and being very transparent. The two most trusted sources of information for me during this time were text threads with friends who are doctors and trying to have them translate things, and using ChatGPT at the time to try to ask questions. What is a central venous catheter? These kind of things. It's all new, especially the unique part of Norse and Fires is it's typically presenting in someone who has not had epilepsy in the past. So everything is new. And that single point of contact, I think it seems echoed across. I don't know who that is and how that works, but that's one big area. How do you communicate a rare disease when it's a suspicion? We had a neurologist early on ask, have you heard of Fires? We suspect it might be Fires. We had a nurse during the night shift when we brought up Fires say, don't Google Fires, which of course I did. And then there's an autocomplete that showed mortality rates up to 30%. So again, trying to discover this, and the information out there is terrifying and not promising. And then slowly it entered the conversation. And I think, Doc, earlier you were saying there's something around there's having a more clear checklist of how do you get to Fires, noting that a diagnosis of exclusion is very difficult to get to because it's not a straightforward diagnosis. Maybe with cytokine readings, it could be more straightforward, but recognizing it's an incredibly complex thing of when and how it is communicated as a suspicion, but coming up with a clear playbook on this, I think is very important. What Janie alluded to in terms of trusting the parents more, this was a tough one. We saw her foot twitching, brought it up, were dismissed. The EEG monitors, recognizing the complexity around this, as we just stared at those, we're told not to stare at those, but of course it's there. You see activity, you try to bring it up. And again, after the fact, recognizing that it's not going to change anything if you see a little activity for the most part, but still how to deal with those kind of signs that are present to parents, I think is incredibly important. And then on the second main area around empathy and stress, and I'm sure this is typical in lots of any PQ situation, but those early decisions, asking parents to give permission for things that they have no idea what's going on or what is happening. I'm not sure how to improve that, but I mean, one of the most awful moments that lives with me. Samaya had blue lined, her heart had stopped. We were basically like sitting on the ground, and then they put her on ECMO. And the decision was, we were trying to ask, can someone please just refer us to, well, can you bring in one of the other doctors? And we were told, we don't have time to get cute. We need a decision right now. And recognizing there's an urgency in some of these moments, but bringing more explanation, empathy, or I mean, it's something that I think the more structure there is around this, it could be an area of improvement. And again, that on the topic of empathy, there's so many different doctors and shifts, and it kind of touches back on the single point of contact. And towards the end, encountering some doctors who, when we were asking questions, were very outright dismissed and even were defending themselves in like saying, I have 27 years of experience. Like these moments, it's tough because there's a lot of good. It's very easy to remember the bad, especially in our situation, and trying to control that across so many people, recognize it's difficult. But again, knowing the multidisciplinary nature of this will bring in a lot of people, but that single point of contact, bringing parents to either feedback in or coming up with much clearer ways of explaining, don't look at the EEG monitor because it's not going to affect any near-term decision because of A, B, C. I think the better these things can be outlined, just the more tolerable at best. Obviously, in an awful situation, it can become. Thank you.
Thank you both for sharing. I really appreciate you, acknowledging that there were some things, that you went well, but yes, we had asked to, address areas that we can do better. And I think you and Desiree really highlighted things that we, is important for clinicians and providers and, the whole care team to hear and be aware of how we can do better. It sounds like you guys had to do a lot of your own, research and trying to understand things in a very acute and stressful situation. Thank you for sharing. That's my too. I'm sorry as well for your loss. I think this will hopefully transition, into hearing from, our two providers that are going to share, their experience. So we'll switch over to Dr. Fisher, who, again, as I mentioned, is an immunologist, but is involved both in the ICU and then afterwards. And then we'll finish up with Dr. Lai.
Hi, everyone. Like Chris said, my name is Krista Fisher. I'm a pediatric neuroimmunologist and also work on the neurocritical care team here at Texas Children's Hospital. And I work alongside with Yi-Chen Lai, and he and I are both very involved in our patients with Norse and fires. And I appreciate Desiree, Jeannie, and Ranjan, you guys sharing your stories with us, because I think that, we live on kind of the other side of things. And so as much as I try to live and be in the experience with you all, it's nice to hear that information from you and hear things that we can do to try to help feel better. Because I think that what I can express is that we, as the providers and the medical team, know that this is obviously a very challenging time that none of us have lived through, and we can't live that experience that you guys have. And we know that there are things that are that there's problems, right, with the way that the hospitalization goes and things that we try to do our best to make it better, make it easier. And sometimes there's just a lot of limitations based on where we are in certain situations. So I think that like part of what Ichen and I want to talk about is a little bit as like why are there certain things that maybe make the communication and the circumstances of what we're in less than ideal, and ways that we can try to help improve that, and things that we've done here to try to help improve that, and our kind of messages to try to help at other institutions as well in other situations. So I think probably one of the biggest barriers and the most struggles that we have is that a lot of like your child or your loved one is in the ICU. And so the primary caregivers and the people that are there, at the bedside regularly are the intensivists. But really the ones that are the specialists in this condition and know the most about the condition is the neurologist and the neurology team. So me knowing as a neurologist that we are not there. So when questions come up or things come wrong, or things suddenly change, if it's the middle of the night and we the neurologists are not there, the ones to talk to you about those things. We're not always the ones that are there when, suddenly, we were in a period where the seizures were doing well, and then the seizures, start back up again, and we're having to bolus and give extra doses of medicines. It's us relaying those things over the phone to the ICU team, and it's the ICU team that's then relaying that information to you all as the family. And then when there's questions, it maybe goes to the ICU team saying, oh, well, we're not really sure the exact information about that. This is what we were told by the neurology team. And we know that that's really difficult. And there's a lot of issues and times that can come up. And a lot of times it's the ICU team is the one that's coming in and checking in multiple times during the day, but not as frequent from the neurology teams. So something that I think that we as a team try to do is terms of having more scheduled check-ins when we're there, in terms of when we have patients with Norse and fires admitted, but understanding that there's sometimes we fail to do that, right? And so a lot of times you might only see from us, one time in the morning when we're coming on our rounds. And unfortunately, there are some times where we miss families, which then makes it even harder, right? Like you guys, someone stepped out to go get breakfast, and then we miss the whole rounding process, and we don't get a really good checkpoint or time to touch base. And we say we'll come back, and then sometimes we don't come back admittedly, or we miss you again. And so there's definitely times where things kind of lapse, and we just have a hard time communicating directly face to face. I'd say I think then the next part that I know is a big struggle in the ICU is that we change, right? The provider, the primary neurologist changes from week to week. Every once in a while, there is a resident or a fellow that's a consistent person that's maybe there for 4 weeks. But we as the attendings maybe change from 1 week to the next. And it's not even just the ICU attending that changed from 1 week to the next, right? It's ICU attending, it's the neurologist, it's the epileptologist that's reading the EEG, it's the neuroimmunologist or rheumatologist, right? So it's like every single face changes from 1 week to the next, and it makes it really hard because then there's not a consistent person, right? So it's not even that there's not a consistent person, there's always not a consistent plan, right? There's a different opinion about, oh, I want to use this medication first, rather than all of a sudden I want to use this medicine, I want to wean, I want to not wean. And so there leads to a lot of variability, sometimes even variability in how the EEG is interpreted of what's a seizure and what's not a seizure, right? And I think even us as the medical team can find that frustrating, because then it makes it hard for us to formulate and develop a plan. And then it makes it hard for us to communicate that to you too. Whereas then we have to come and say, I know this is very confusing and it's frustrating for me as well. Is that something that, the person that was reading the EEG last week didn't call a seizure, now all of a sudden this week is calling a seizure. And so now we're having to kind of step back and change the way we're doing things. And it leads to a lot of inconsistencies, which I think is so challenging. So I think in our institution, we do have kind of a team of like champions of like fires and Norse champions that are the people that are really invested in the patients. And we try to schedule, regular meetings, and we talk about the patients, even we're texting from one day to the next, even if we're not there at the bedside every day, to try to provide consistency. We try to have like a regular multidisciplinary meeting, whether it be once a week, even sometimes more frequent we need it. to show a consistent person, to try to help develop that consistent message and a consistent plan. But it is challenging, right? Because as you know, with our schedules and vacation and clinic times and things like that, I can't always show my face in person, or just variability in terms of even like the ICU team. They might be on, our ICU provider that's the consistent person, might be on overnight. And so then they're not there for the rounding time during the daytime to be present. So I think that there's a lot of times where even where we try to make this consistency and develop some kind of consistency for you, there are still times where sometimes it falls through. And I know it can lead to a lot of this ping-ponging back and forth kind of feeling that can be so frustrating. But I think that like we are trying very hard to make develop multidisciplinary meetings. Is it once a week? Is it multiple times a week? In the acute early phase, in the first few days, is it every single day that we're trying to get all the teams to come together and round at one time? The ICU team, the neurology team, to bring the epilepsy team there too. And so that we're all sitting and talking together and speaking the same message to you at the same time. So it's not just one message that's delivered from the ICU team at 8 o'clock in the morning, and then the neurology team comes at 9 o'clock and sends a different message. So I think trying to have this practice, especially very early on in the situation where the teams meet and they come and they talk to you all together at one time, and then identifying somebody that is your champion, right? Like, I want this person to be my primary ICU doctor, my primary neurologist. And then it leads to the next factor of then when we get to that next point of that transitioning out of the ICU, because then all of a sudden your team changes again. And so trying to find somebody, maybe I say someone that plays for both teams, an inpatient side and the outpatient side, that can be a consistent person to try to help that transition period of going from, the ICU to the acute care floor to rehab, then to outpatient, right? Because then it's somebody that's been with you along your journey, that can kind of have lived that experience with you and can relate to the things that you've gone through. I think it's hard because there's not always that person at all those places. But I think it's something that is needed in trying to identify somebody, especially in these difficult situations, to give you all somebody that's a consistent person, because I think that is probably the hardest part, right? A consistent person that can relate to what you've been through and send a clear, consistent message throughout kind of not just the hospitalization, but then transitioning to home as well. So with that, I'm going to give Yi-Chen a chance to talk a little bit as well.
Thank you. Hi, everyone. I'm a pediatric intensivist by training, and I guess I can give you a little brief introduction in terms of how I got into this field. I remember for those of you who heard my talk before, heard this story before, I remember the first case that I, now in retrospect, probably is a teenager with fires back in early 2000. So this is actually when I was still in training. And I still remember exactly where the bed is and what we thought that he had. Now, fast forward about 10 years, at Texas Children's, one of my senior colleagues basically told me that, I was actually a basic scientist. And she told me that while basic science is great, but if I wanted to make meaningful patient impacts, this is the fires and Norse. And back then we didn't even have the proper language. It's the place to go. And so here we are 10 years later. And I do actually have to say that out of all my research endeavors, taking care of children with fires and Norse probably is the most challenging. And in some regard, it's also the most rewarding. You have heard, that about some of the challenges, mostly sort of it's structural challenges. So I'm not going to belabor that, but we do hear you loud and clear. And so at least at the institution where I'm at, one of we trying to there are three guiding principles that we're trying to live by. One is consistency, clarity, and communication, right? And Kristen already sort of tell you about what what we're trying to do with each one of those areas. The part that's unique for the ICU are as follows. One, all the frustrations that you have expressed, we feel the same way. Can I find a neurologist who will make a decision? So can I find an EEG person to tell me exactly whether or not the kid is having seizures or not? The same feelings that you share with us, we feel the same way. Now, what's unique about the ICU is that you have to, like we by nature, have to form a very intense relationship in a very short period of time, right? Because none of you have met your intensivist. And so I think it's actually mostly an art than a science. Now, even though fire is a predominantly a neurologic conditions, but as you all have lived through, there is a whole bunch of body problems that we had to deal with, right? And so one of the things that we try to do better is trying to basically have more engagement from the intensivist. You know, this is a Norse Institute, and I am kind of sad to say I may actually be the only intensivist who spend enough time in this forum, right? So one of my tasks is trying to engage the intensivists a little bit more to empower them a little bit about, yes, you're not going to be the expert on this, but certainly there are certain things that you can say um, that that's knowledge based, right? So you're an expert in managing difficult to control status. That's our bread and butter. The other part that I wish that we probably can do a little bit better is about sharing the information. Now, that's always a sort of double-edged sword for us, right? Because when you first meet the families, I'm not sure whether or not that's the right time to basically pull out the outcome papers and they say, hey, there's a 30% mortality rate, right? But I do think that kind of frank discussions probably should happen much sooner than what we currently are doing. And in fact, that's usually one of my sort of practice now, which is as soon as the dust settles a little bit, usually I start sort of talking about outcome. Some of the family may not be receptive even at that point in time, but at least they can say that, they sort of find out, later on. The other two areas that I think we should do a lot better is sort of recognize when when we need to sort of refocus the priorities. Because, all along, and myself included, right? We always think that it's a problem that can be solved. And next thing you know, 2 months down the road, the kid is still having difficulty to control seizures, and now you have a whole host of problems that is associated with a prolonged ICU stay. And then at that point in time, when we're trying to sort of transition to maybe this is a losing battle, if that's the time we start introducing it, it becomes a much difficult conversation. And then the last part, which and you guys are all lived through, is the battle is not won, right? At the end, once you leave the ICU. And in fact, that's where the battle begins because now you're at the chronic phase of how do you sort of take care of or live with a loved one that just went through fires. And hopefully it's going to be a long life, but it's much more challenging. And so for the ICU, our job ends, when they transfer out of the ICU, and then we say, congratulations, pat ourselves in the back, and say, hey, we're done. But in fact, I don't think we have talked a lot. And we try we're trying better now in terms of sort of projecting at least sort of introducing the idea of chronic phase much earlier on. But we are trying. So, and thanks for listening.
You all, I think, Kristen Chen, you really highlight some, key points about the importance of each and I wrote down consistency, clarity, and communication. And then Kristen, you sharing the efforts to have more touch points, with the whole team and multidisciplinary engagement. Thank you, Chen. You also highlight something that I discussed a little bit yesterday too, that in some of the interviews I've done with patients and families that I know you didn't mention this as much when you were discussing it, but that it can be one of the other challenges around communication and discussing prognosis too, is if the people haven't seen kind of the long-term outcomes as well, and due to the rarity of the diagnosis, but also I think, like you mentioned, in the intensive care unit, the intensivists, after they leave the ICU aren't, still involved. And so they don't, have that perspective in the same way of the long-term outcomes. And so I think, again, is something that we really appreciate everyone sharing their stories and helping to, spread awareness and knowledge about the patient and family perspective and outcomes and things like that, that are really important as we're having these conversations. So thank you to everyone for sharing. I think it looks like Kate put a comment in the chat about how their intensivist was really so helpful in their experience with their intensivist, which is great to hear. We are going to move on to another topic that has come up with, I think, lots of questions from patients and families. So we wanted to include it into the family conference this year. So we're going to hear about different neuromodulation treatments for Norse and fires. And so Dr. Mantone from King's College is going to share with us. And again, remember to put any comments that you have in the chat, and then this will be followed by the Q&A session. So you also have an opportunity to raise your hand if you have questions at the end as well.
Thank you very much, Krista, for the kind invitation and for the introduction. Krista, can you hear me all right? Can you hear me?
A little like staticky and cutting in and out.
Yeah.
That's just
really. Let's try this one. Just one second. Can you hear me on this one? Let me share the screen, and at least you can see the slides, and then I can advance the slides on the presentation. And can you see my screen?
yes.
Yeah, you can see. You can't hear me properly?
It's still very kind of staticky and seems like it's cutting in and out a little bit.
Okay, then let me give me a few seconds. I'll try and log in and have the microphone on another device. My apologies. I will switch off. Where is the? Sorry.
Laura, I just sent you some instructions of other things you can do.
Laura, did you have a question you wanted to ask now while
Yes, while Dr. Mantone is working on the audio, I just wanted to point out something that Desiree had highlighted that resonates with our experience, which is very old, almost 13 years. We lost our son. That there is a practical and structural limitation to the information flow in hospitals, because the doctors rotate on and off every week or so, and the same thing with the residents, maybe every couple of weeks. And they also reside on different floors. And so we also found that the information was siloed. There's a problem with communications. But we found that the people who were most in touch with our case were the nurses. They had their own communication pool. Apparently, in the nurses' room. They discussed our son's case, and they had found a way to communicate continuously about my son's case. So I just throw it out there to the doctors who are on. We don't have any nurses, but to talk with some of the nurses and see if what do they do to keep track of their patients in a way that might be different from the doctors. And Laura, I see you're on again, so I'm going to lower my hand.
Thank you. Can you hear me better now?
Oh, that is much better. Thank
Okay,
you.
great,
Sorry
great.
to
So
have to
I
switch
have,
over.
this is the NHS for you. My apologies. Great. Well, thank you very much. Thank you for sharing all your stories, both doctors and families. And I really absolutely share, your experiences. And this is exactly what has driven me and our team to do research into Norse and set up a Norse group also in the UK. So I work at King's College Hospital in South London. You can see there, and it has both pediatric and adult services. And today I was asked to talk a bit about neuromodulation. In that, I will use some acronyms that I will explain to you. VNS, DBS, RNS, and I'll quickly go through the techniques with you. I've briefly reviewed the current evidence, and as you will see, there is not very much. And then I will tell you about our research at King's. So VNS stands for vagal nerve stimulation and is a form of indirect brain stimulation. It has been around for a very long time, so since the 1990s, and essentially it consists of a battery pack that is implanted under the skin in the chest, a bit like a pacemaker. And the wires are tunneled through the skin into the neck and are wrapped around the vagus nerve, the afferent fibers that lead into the brain. So it's a bit like a pacemaker, only that the wires are tunneled up and stimulate the vagus nerve in the neck, not in the brain, instead of going into the heart. The vagal nerve stimulator is always on and can be switched on additionally by giving extra pulses by using a magnet. Trials have shown that it leads in an about 50% seizure reduction in up to 50% of patients, but it can take up to 1 year to reach its full effect. So normally it is used to treat drug refractory epilepsy, and it is titrated a bit like a drug over several months. And we know that children benefit more than adults. Then there are two other brain stimulation techniques, which are direct brain stimulation techniques. So they go into the brain and you need to open the skull. One of them is DBS, or deep brain stimulation, and one is RNS, or neuropace responsive neurostimulation. So the deep brain stimulation is very much like the deep brain stimulation you can use for tremors in Parkinson's disease. And it consists of two electrodes that are inserted and stimulate some of the deep thalamic nuclei in the very center of the brain. And the one type of stimulation that has been used in Norse is called centromedian nuclear stimulation, which is one of these deep thalamic brain structures. The neuropace responsive neurostimulator is a set of electrodes that is placed on the surface of the brain and stimulates constantly. Those techniques so I've put the kind of key trials, if you're interested, that demonstrated efficacy. And as you can see, the efficacy is pretty much like the one of vagal nerve stimulation. So about 50% reduction at 1 or 2 years in about half of the patients. With this one, you have the advantage that you also record EEG at the same time. And in the States, all of them are approved. They're FDA approved, whilst in Europe and certainly in the UK, we do not have approval for the responsive neurostimulator. And unfortunately, we are very limited as to the use of deep brain stimulation for epilepsy. And all of these have been used to treat focal epilepsy in particular, but centromedian nuclear stimulation has been used by a team at King's and by other colleagues for generalized epilepsy as well. So here just a brief graph to show you how VNS implantation for Norse is done at King's. So if you look through the literature, there are reports of cases of status epilepticus, so not Norse, as difficult to control status that have been treated with VNS. And under that, let's put it under that indication, and often as a palliative procedure, we are allowed to implant it in patients with Norse and super-refractory status. Obviously, it goes through an epilepsy surgery MDT, and we implant it. Now here to highlight, the VNS is switched on the day of implantation, which would not normally be the case. Normally you would switch it on about a month after insertion. And as you can see, within about 1 week, the stimulation parameter, so you can change the current, frequency of stimulation, you know, how long the pulses are, how often it goes on and off. And these values are up titrated to pretty much standard values within 7 days. So normally in focal epilepsy patients or generalized epilepsy patients, it would take you at least 6 months to get to these values. At King's, we implanted adults, so 2 adults in the acute phase of Norse, so in the first 30 days of presentations, and 1 lady was later on in the chronic phase. The most recent case we've had in April was implanted on day 17 and did very well. I think there were just a few points I wanted to share with you. One of our cases we implanted in the acute phase was actually a young woman who was pregnant in the first trimester of pregnancy, and I think it was very, very important to show and demonstrate that actually it is safe to use VNS if women who are pregnant are in status epilepticus. It doesn't lead to any fetal compromise. It might lead to the woman requiring a C-section, but there is no direct link to VNS. And there is no adverse effects also looking through the literature. And the justification we always give is that even though it might not be helpful to take the person out of status, we know that people with Norse and virus end up having long-term chronic epilepsy. And so VNS, is known to help people with chronic epilepsy to reduce seizure burden and also anti-seizure medication load. So that was quite important learning point. So in the next 2 slides, I will show you what is available in the literature about the use of VNS in Norse. So there were 15 cases treated, 10 adults, 5 pediatrics. All pediatric cases were virus. The adults were up to 49 years old, and the children ranged between 17 months and 14 years. As always, it is very difficult to have very standardized information, and I think this is what we're working towards within the Norse Institute and all the Norse subgroups, is to really make sure that everyone collects the same amount of information on patients. So 5 cases were implanted within the first month, and 7 in the phase of treatment-resistant epilepsy. And as always in these cases, it is very difficult to say it was VNS that got them out of Norse, because often multiple interventions are done at the same time. So here is just a crude summary of the outcomes. 4 cases, in 4 cases, VNS was felt to lead to cessation of status. In 3, it led to sustained seizure reduction and ability to wean off the general anesthetic and to be able to assess the patient. 2 died, and we have very little information about the long-term functional outcome, available only in 8 patients. The best case was a child who resumed schooling, and there was no big difference, but I have to say there are very few cases, so there was no huge difference of whether it was implanted in the acute or chronic phase. But I think to highlight is that it is generally well tolerated without significant adverse effect. The procedure is not major. VNS was switched on swiftly in all cases, rapidly increased, And clinical changes were documented fairly soon after the VNS implantation, and benefit was sustained long term. And here, as you can see, the very scant literature about the other modes of direct brain stimulation. As I've said before, the deep brain stimulation for Norse and Virus reported was only stimulation of the centromedian nucleus. You can also stimulate other nuclei for focal epilepsy. And here there were four children, 3 Virus, 1 Norse. They were, as you can see, implanted towards the end of the acute phase or in the chronic phase. And the reports describe that DBS might have stopped secondary generalized seizures, but not focal ones. And in one, it did partly resolve status. One child improved later on with anakinra. Regarding responsive neurostimulation, was only used in a chronic phase, so to treat refractory epilepsy as a consequence of Norse, so not the acute phase. And here we have for 5 adult patients and 1 pediatric patient. 2 of these had had VNS inserted before. So in this number of patients reported, so it's one series and 3 individual case reports, RNS was implanted really quite late into the disease, so up to 84 months after the onset. And reports of benefits in summary describe reduction of seizure severity, fewer focal to bilateral seizures, and perhaps a shorter duration of seizures. In some cases, it helped distinguish seizures from episodes that were not epileptic. So overall, in terms of VNS, which is the modulation technique, which is less invasive and where there is more information about, we think that it is worth considering as a long-term option to, hopefully help with the acute phase, but also in the long term to reduce seizure and anti-seizure medication burden. And so really the question we were asking is, as you can see, everyone really waited quite a lot to implant. So would earlier implantation perhaps allow us to desynchronize these rhythmic discharges and the networks that lead to this difficult to treat status, perhaps limiting the seizure spreading? And does VNS have a long-term effect on neuroinflammation and actually the generation of a brain and the enduring predisposition to generate seizures? Because we know that VNS is being used also in inflammatory bowel disease, as it does have an effect on the inflammatory cascade as well. And so this is what led us to apply for some funding to set up a trial to use VNS in treating Norse, and it is currently funded by the Charles Sykes Memorial Charity Grant. And what we want to do, or what we are doing, so there is the ethics application is in process, is to set up a multi-center trial. So in a condition which is as rare as Norse, you will not be able to set up a classical randomized controlled trial, which is really the golden standard to test, medication comparing an intervention against control. So the way you can approach this in very rare diseases is by calling it an N of 1 trial, which means you treat 1 individual, and I will show you how this is done. And by pooling several people who underwent this treatment, you're able to generate some statistically significant conclusions. And so what we want to look at is whether vagal nerve stimulation can be an additional management option in reducing severity of seizures and status. That's the primary aim. As I probably haven't mentioned yet, is the actually mechanism of action of vagal nerve stimulation is really unknown. We think that there is modulation of brain activity through the electrical stimulation of these afferent fibers going into the brainstem, and partially, as I've alluded before, by a modulation of the immune system. But the honest answer is that really no one knows. So the second aim really is to establish if the vagal nerve stimulation has an immunomodulatory effect, and whether we can measure inflammatory molecules, and whether that can be used as a biomarker of the effect of VNS, and perhaps help essentially stop the inflammation that is thought to be involved in Norse. This is embedded into Norse UK, which is now part of the Norse Institute, which is essentially our multi-center network in the UK that we set up. So what we are going to do is we are going to include adults and children with Norse or virus, hopefully being able to recruit 10 to 30 cases over the next 5 years. And what we do, and that I have to say is our standard of practice in the UK, is we offer a meeting. We also participate in the international MDT meetings, but we have a special epilepsy surgery meeting where we discuss suitability for vagal nerve stimulation very early on with the treating teams, and that is, as early as we can, ideally within the first 2 weeks post onset. Obviously, any other management, be it immunosuppression, anti-seizure medication, anesthetic management, continues completely unaffected, throughout the study according to local and national guidelines. And then this is what you normally do for one of these trials, is that of course you have a period, a run-in period of observation, which is the first presentation. And typically what you would do is you would treat the patient, stop treatment, treat again, and then finally evaluate. Now, it is very clear that, and I will show you in a few slides, that you can't stop the VNS if it has worked. How do you assess whether it's working or not? Obviously clinically, but obviously by doing continuous EEG or daily spot EEGs, and by measuring serum and CSF cytokines, which are essentially markers of inflammation, little molecules in the blood that are released by inflammatory cells. So we want to know, the primary endpoint is whether it helps stop status epilepticus. Of course, if people respond to it, we will continue it. We will not switch it off, and we'll continue it for at least a year or as long as clinically indicated. In those where it doesn't stop the status and it just continues unabated, we will do this this period where one will switch off the VNS, continue to review, and then switch it on again and leave it on because it might have a beneficial effect on chronic epilepsy. And I think this really brings me to the end of the presentation. Here are our funders and all the people who collaborate to the project and to Norse UK. And I will stop sharing now. And if there are any colleagues on the call and are interested in collaborating, I'm very happy to be contacted about this. Great.
Thank you so much for sharing and giving, an overview, as well as, the research that you guys are doing, looking into VNS, farther to understand, how it's helping and if it's helpful. I am going to switch over to Dr. Gofton to lead us through our Q&A.
Thank you. So I'm Tennille Gofton, neurologist, and I also work in neurocritical care. Our goal for the next few minutes, I think about, let's see, at least 15 minutes and a little bit more, is to have an opportunity for question period related to what we've talked about so far. So I think it's a great opportunity to raise your hand and ask a question directly if you'd like, or to pop a question into the chat and I can read it out to the group and direct our answers. I can start out with a question if folks are still thinking of theirs. Dr. Mentone, thanks for an interesting presentation and a really great proposal that you outlined. I wondered if you could speak to the fact that when we put in a vagus nerve stimulator, it's often a permanent intervention, and what your experience is, how it helps in the acute period versus the chronic period.
Yeah, I mean, as I think I alluded to before, is that we know exactly that patients with Norse and virus and end up with chronic drug-resistant epilepsy. That's the norm, and therefore, of course, we are embarking on a long-term, permanent treatment. But the hope is to reduce the seizure severity, seizure duration also in the longer term, and help reduce anti-seizure medication burden as well. So VNS, in our experience, has a benefit. So I have to say we implanted 3 patients, and all of them did very well with the VNS. 2 of them came out of status. So it had a significant effect. And in my general practice of looking after patients with chronic drug refractory and genetic epilepsy, VNS, whilst not with all of them, it can improve quality of life and seizure burden significantly. So in that sense, you justify a long-term permanent intervention, knowing that this intervention is likely helpful also to manage the longer term chronic epilepsy that these people might be or will most certainly be left with.
Thank you. That's helpful. We have a couple of questions in the chat. One is from Luke Boulian with a question about the deep brain stimulators and if that helps generalized epilepsy or only focal seizures, I believe. Luke, speak up if I didn't represent that properly.
Yeah. Hi. So deep brain stimulation. If you, so generally speaking, if you stimulate some anterior thalamic nuclei, and it might depend on the center's experience, it is used to treat focal epilepsy. If you stimulate the centromedian nucleus, it has been used to treat generalized or refractory generalized epilepsy, absence epilepsy. Yeah. So in the chronic epilepsy patients, it can, in the Norse population, in the studies, it's not studies really, in the case reports, it kind of helped spreading the focal seizures to become generalized seizures. That's what the 2 case reports report. So it was patients who were having seizures starting in one part of the brain and then rapidly involving all the rest of the brain. And these in these generalized seizures affecting all of the brain were stopped. So the patient continued to have focal seizures.
Thank you. We have another question from Anil. The question is, in someone who has 90% of a small intestine, I assume that's after having had some surgery, how would VNS impact that, and does it make a difference?
It is a very good question. I mean, I have to say, I'm not aware of any contraindications if you have a smaller intestine to VNS. So we also don't really normally, so the VNS is thought to stimulate the afferent fibers, so the fibers going into the brain rather than the fibers going into the lung or into the gut. Now, exactly how the vagal nerve stimulation modulates the immune system of the gut, I think is very little understood. But we don't normally have difficulties with, let's say, frequent bowel movements or diarrhea or any gastrointestinal problems in patients who have a vagal nerve stimulation. What they may get is a hoarse voice, a bit of pain, if the settings are too intense, and you can change that. So in my experience, I'm not aware that having a small intestine would be impacted by VNS, but one would have to perhaps look up the gastrointestinal literature, but certainly not in the chronic epilepsy population. I've never had any problems with gastrointestinal dysmotility.
Thank you. And there's a question from Jennifer. Do the seizures coming, or can VNS be used to treat seizures coming from different parts of the brain?
Yeah, absolutely. So vagal nerve stimulation, the honest answer is it stimulates the brainstem, but how exactly it works is not understood. So absolutely. So most patients who get the VNS have either what we call multifocal epilepsy, so seizures coming from different parts of the brain, or generalized epilepsy, so seizures coming from the entire brain. For example, patients with Lennox-Gastaut syndrome. So many of them have a vagal nerve stimulator. So absolutely.
And the next question is from Anil again, a different question. Is there a cookbook for prescribing VNS or RNS based on EEG data?
So I assume on the EEG data in the kind of whether in the acute or chronic phase. So we're talking about Norse here, isn't it? So the answer is no. I think in the UK, the answer is also pretty straightforward, that only VNS is licensed. I have to say, when we designed the trial, we did think about DBS because our center does implant DBS and RNS. But it is a lot more invasive. So you definitely need brain surgery. VNS is a lot simpler. In the worst case scenario, could be done in an intensive care unit, and the efficacy is pretty much the same. So that's why we chose vagal nerve stimulation and the additional potential neuromodulatory aspect. So it's simpler also in resource limited countries. It's cheaper, and there is more long-term data, but there is no EEG data that will necessarily guide you in Norse of what to use. Obviously, if you have a focal epilepsy, a focal refractory epilepsy, that's a different discussion, I think. But for Norse, definitely not.
Thank you. And I might add to that if that's okay. Published, there's a few different or several different approaches to increasing the vagus nerve stimulator if it's put in during the acute phase of Norse. And then in the more chronic phase, as you outlined, essentially, there's lots of different ways to increase and change the vagus nerve stimulator, but that depends a lot on what kind of side effects or feelings people are having with it and what kind of seizure control they have along the way. Dr. Mantone, could you speak to any cognitive effects you can see with the vagus nerve stimulator?
No, not really directly. So whilst, for example, when we use cannabis oil in people with very severe epilepsies like Lennox-Gastaut, you anecdotally, you do see sometimes some lightening up or some kind of people becoming more aware, etc. I don't think there is a direct cognitive effect of vagal nerve stimulation. I mean, in the cases we have used, in 2 cases, it terminated the status and it allowed us to wake up, the patient. One of them did very well, but that's a result of them not being in status anymore rather than a direct cognitive effect. And I don't think we've really noticed it's difficult to disentangle, isn't it, often, as whether it is the fact that you are not seizing all the time anymore, that you're able to have less medication that is very sedating. So it might be a combination of things.
Thank you. There's one slightly more general question that I'm not going to skip it, but I'm just going to, I think, go to the VNS questions first, and then we'll come back to that one for sure. There's a question on Dr. Mantone. How could we make other clinicians aware of your study?
So you can certainly share my academic email address. I did present the study last year at the Norse Scientific Symposium, just as a short presentation, and perhaps we could publish something on the Norse Institute website as a link or something. That might be a good idea. It would be really immensely helpful, and we would be so happy to have participating, centers, and because obviously we would be collecting longitudinal data and then write, results up all together. So the more people contribute, I think the more informative the study will be.
Great, thanks. And there's one more VNS question about side effects. Somebody's outlining that their family member has side effects, including headache and anxiety. Are those related to the vagus nerve stimulator, or are they common side effects?
No, we don't really normally hear a lot of headache. Obviously, VNS is not a golden treatment, the easy one that no one was thinking of. Absolutely. So it works for some, but not for all. So it works in up to 50% of patients. In some people, it doesn't really help at all. So it's really difficult to say. I don't really think we have headache or anxiety necessarily as a typical side effect in our also chronic epilepsy cohort.
Thank you. The last question I think is more general for all of the pediatric neurologists, especially on the line. It relates to early puberty, and a young girl at age 5 had fires and is having multiple medications to help control seizures, but also experiencing early puberty. And if there's a good resource, either nationally or internationally, for understanding that better.
To chime in, certainly if any of my colleagues want to chime in about that as well. I think from when I last looked at the literature in terms of thinking about different hormonal changes, whether that be, early puberty or other kind of evidence of adrenal insufficiency after Norse fires, there's not any literature out there that I could find, but I will say kind of anecdotally, this is something where I've had some patients be followed by endocrinology for different hormonal deficiencies. And so it sounds like this person has been referred to endocrinology. I think they'll really be able to help evaluate further and understand, when we think about hormones, whether that be, hormones related to puberty or hormones related to controlling your cortisol levels or other parts of your body, it can be, central, meaning coming from the brain versus the specific organ that's secreting those hormones. And so I think certainly, something that again is not well reported in the rarity of, Norse and fires, but important to also involve endocrinology in terms of better understanding that. I don't know if any of our other neurologists or pediatric neurologists on have different thoughts about that.
Okay, thanks. So obviously it sounds like working with the neurologist and endocrinologist together on that point is really important. There is one last question that's come up, Dr. Mantone, about the vagus nerve stimulator and battery life. Can you comment on that?
Yeah, absolutely. So that it really depends on how the VNS is set up. Also, some of the more modern VNS devices have an auto-stim function. So the VNS detects heart rate variability and can give extra pulses when it detects some imbalances that it interprets as seizures. Nevertheless, you cannot use a readout from VNS to extrapolate how many seizures you are having, but you can read how often the auto-stim function kicks in, and obviously that uses the battery a little bit more. It also depends on how many times you use the swipe function. So some patients find it helpful when they have an aura, or some carers, if they can see an aura happening or a seizure starting, they swipe a magnet. So they have a little handheld magnet and you can swipe the device and it can help lighten or stop the seizure. So normally the battery is read out with a a little wand device. So the patient is asked to come to clinic, every 6 months or every year. And the battery triggers amber at some stage. Then you need to review the patient a bit more frequently, and at some stage when it triggers red, they have to have a battery replacement, and they have to be put on a battery replacement surgical list, which is normally a day case procedure, where it's just literally a battery under the skin that is replaced, not the whole wires. The wires stay in. So it can really range from 3 to 4 years to longer, depending on what the settings were and how often it is used. Yeah.
Yeah, I'm going to jump in really quick too, just in terms of, as I was talking about from the early puberty standpoint, I think I was getting ahead of myself a little bit, but thinking about, is it coming from the pituitary in the brain versus the other organs that can be involved in hormones? So I just wanted to clarify that point if I hadn't said it, clearly in my response. But
Thank you. Are there any other questions that folks would like to either raise their hand and say aloud or put into the chat? For everybody's knowledge, Nora, after the session, this is posted on the Norse Institute website, correct?
What are you referring to? What is posted?
Are some of the presentations available to be viewed afterwards? I think there's just some questions about contact information.
Well, no, only the schedule is, but
Okay.
I believe given the interest in Dr. Mantone's project and in neuromodulation, I think we can put together, I will ask Dr. Mantone to put something together, and with her contact information and the ways to enroll in her study, and then they can go to that pretty soon. So thank you.
Brilliant. And thank you. And we do have now 2 families representatives also in the UK. So if you let Nora know if who you are and the reason for making contact, then we can absolutely channel the request and put you in touch with our families. Yeah.
Yes, and I should say that there is a UK Norse group growing, and Laura Montone is part of it, as well as Marios Kaliakasos as investigators, and Rachel Liu is leading that branch of the Norse
Exactly.
Institute.
Yeah,
So
absolutely.
she's on right now, and she'll be leading one of the groups.
Oh, brilliant.
Groups.
Super.
Thank you.
Okay, and I think we have one last question that just came up about the vagus nerve stimulator, since we're not quite at 11:30. The question was the 50% improvement with vagus nerve stimulator, is that specifically for Norse or for general epilepsy? And is it
No,
just
that is
VNS or both VNS and RNS?
So I would say, as a generic statement, for all the direct and indirect neuromodulation techniques, the efficacy in drug or in treatment-resistant epilepsy, so not Norse or status, is 50% seizure reduction at best, in about 50% of patients at 1 year. But this is a group of very diverse people, of very, epilepsy of very different causes. And that's again why it would be really important also to stratify, the Norse subgroups and virus, and certainly the timing of insertion, I think, is crucial. Yeah.
the other thing I was going to add about
Thank you.
that is that neuromodulation devices are one type of treatment that actually can get better over time. And so when they've done the long-term follow-up studies for different neuromodulation devices, we can see increasing efficacy rates over time. I know that's hard if someone's having a lot of seizures to wait for that, but the rates of seizure reduction can increase a little bit more over time the farther years you go out from implantation.
Absolutely.
Wonderful. So, Dr. Eschbach, do you want me to wrap it up for break?
Yeah, and I'll share my screen. I'll let you wrap up while I'm sharing my screen for the survey that we have about communication for family members and caregivers who are on. If people want to do it during the break, feel free. This is about communication in the ICU, so does not have questions that we would be having patients answer. We'll do kind of, that's a next steps looking at communication, but for anyone who wants to do this during the break, should just take a few minutes.
Great, thank you. So the break is from 11:30 to 11:35, and we'll come back afterwards for the different breakout sessions, which means you can choose the discussion room that is most of interest for you and your experience. And we'll go from there. So at 11:35, thanks.
Some of you, if you're doing the survey right now, you may still be working on it. And that's okay. I think certainly you can take your time. We will kind of start our transition into the different breakout sessions. So I wanted to share this slide here so everyone can see the different sessions. I think we did have you when you registered. You could have selected a session, but we realized people could have selected more than one session, but they are all running concurrently. So you'll only be able to be in one session. There is one that'll be led by Nora and Rachel on directing grief towards purpose. We will have a breakout session talking about long-term outcomes, so some of the research updates and planned projects. That'll be led by myself and Tennille. And then also a session led by Coral Stredney, Dr. Stredney from Boston Children's Hospital, who you guys have not gotten to meet yet, but she will lead a session on anti-seizure medications and side effects and how they are managed. And so I think, Maggie, you can tell me if I'm incorrect, but you guys will be able to select which session you want to go into. If you end up with the wrong one, you can select to leave the room and go back to the main breakout room, and Maggie and Matthew will help get you in the right place. This year, we're trying to do more time for our breakout sessions. It seems like every year they're a little bit too short, and so we'll be able to be in them until 12:25. So about 50 minutes, and then we'll come back together for a brief wrap up. So we should hopefully have more time than other years to really, have some nice discussion as well as sharing of information before the discussion period. Maggie, I don't know if you want to add anything about the logistics of how we'll get to where we need to be.
Yeah, no, that was perfect. Just feel free to come back to the main room again, as Krista said, and we'll be happy to help you.
Great. Well, I really, so hopefully the breakout sessions, everyone hopefully felt like they had a little bit more time this year and time to have a, good discussion and ask questions. I think certainly, at times it feels like we always could use more time, but I think hopefully this increased time from last year was helpful. For our wrap up, I was just gonna, thank everyone for attending and participating. Thank you to all of our speakers. Again, Maggie and Matthew for all their work in organizing it. And again, we couldn't put this all together without Nora and everything she does as part of the Norse Institute. Certainly feel free, to reach out and give us feedback about the conference or things you guys would like to see in the future in terms of different topics or any, thoughts about the structure, things like that. The other thing I am going to put up just one more time is that link to the survey for patients, or not for patients, but for I said for patients and families, but it should be for families and caregivers about communication. So if you guys during the acute ICU stay, so if people haven't done that and they want to, we'll also put this on the Norse Institute website. So no, pressure. You don't have to feel like it's something you have to do right now. And then otherwise, I really just want to thank everyone for their attendance and participation. Nora, I don't know if you have anything, closing remarks you want to add. I know you were not going to say anything, so.
Just thank you.
Yeah, I really should say to our family speakers too, thank you for, sharing your experience and being open and honest about that with us.